Welcome back to our deep dive series. Today, we are tackling a really big one, adrenal drugs. You know, the class that seems to touch everything: stress, metabolism, inflammation. Yeah, if you're trying to get your head around this core chapter, maybe for an exam or just for clinical practice, this is for you. We're aiming for a quick but thorough review. We're talking about those adrenal glands, tiny little things sitting right on top of the kidneys, but wow, they have a huge job.
They really do. They're like these little command centers. And when they get out of balance, well, that's where pharmacology steps in with some pretty potent tools, the steroids.
Okay, so let's set the stage. What's our main focus within adrenal drugs today?
Right. So the absolute key term for today is corticosteroids. And it's critical right off the bat to remember the adrenal gland has two distinct parts. We're focusing entirely on the outer layer, the adrenal cortex. That's where these corticosteroids are made.
Not the medulla, then.
Exactly. The inner medulla, that's all about epinephrine, norepinephrine, your fight or flight stuff.
Yeah.
Totally different topic for another day.
Yeah.
Today, it's all cortex.
Got it. Cortex it is. So this cortex, it takes cholesterol and turns it into these steroid hormones. You mentioned there are different types.
Yes, two main categories you absolutely need to know. Glucocorticoids and mineralocorticoids.
Yeah.
Functionally very different.
Okay, let's break those down. Mineralocorticoids first.
Sure, the name gives it away, really.
Mm.
Mineralocorticoids manage mineral salts, specifically electrolytes. The main one, the prototype, is aldosterone.
Aldosterone. Okay, and how does it work?
Its mechanism is pretty direct, actually. It targets the kidney tubules and basically tells them, hold on to sodium, resorb it back into the blood.
Just like that. Hold the sodium.
Well, there's a catch. It's an exchange. To get that sodium back, the kidneys have to kick out potassium ions and hydrogen ions.
Ah, okay, so it's a swap. Sodium in, potassium, and hydrogen out.
Precisely. And you can immediately see the impact, right? It affects blood volume because water follows sodium. It affects potassium levels, obviously. And because it's moving hydrogen ions, it impacts blood pH, acid-base balance.
Wow, okay, so that one hormone has quite a reach.
It really does. Now, the other side of the coin is the glucocorticoids. Cortisol is our natural example.
And these are the ones most people think of as like the anti-inflammatories.
That's their claim to fame, definitely. Pharmacologically, when we give glucocorticoids, they are incredibly potent suppressors of inflammation. I mean, they shut down practically every step of the inflammatory and allergic response. They're the real heavy hitters for immune suppression.
But it's not just inflammation, is it?
Oh, absolutely not.
Huh.
They're crucial for metabolism, how we handle carbs, proteins, fats. Huge role in the body's response to stress, major stress. And it's worth noting, even natural glucocorticoids like cortisol aren't perfectly clean. They usually have a little bit of mineralocorticoid activity, too.
So even cortisol can affect fluid balance a bit.
Yep. It's usually minor compared to aldosterone, but it's there.
Okay, so we have these two types of hormones being made in the cortex. How does the body control this? There must be a regulator.
There is. It's a classic feedback loop called the hypothalamic pituitary adrenal axis, or HPA axis. This is fundamental.
HPA axis.
Right.
How does that work? Is it complicated?
It sounds it, but the concept is straightforward negative feedback.
Yeah.
The body doesn't really store these steroids. It makes them on demand. So it starts up in the brain, the hypothalamus. It releases a hormone, CRH.
Okay, CRH from the hypothalamus.
That CRH travels just a short distance to the anterior pituitary gland, also in the brain, and tells it to release ACTH.
ACTH. Got it.
Then ACTH travels through the bloodstream down to the adrenal cortex, and that's the signal for the cortex to start pumping out corticosteroids.
So hypothalamus, CRH, pituitary beta, ACTH, adrenal cortex, beta, corticosteroids.
You got it. And the negative feedback part is key. When the levels of corticosteroids in the blood rise, that signal goes back up to the hypothalamus and the pituitary, basically saying, okay, levels are good, you can stop sending the signals now. It shuts off CRH and ACTH release.
Neat. A self-regulating system. So if it works so well, what goes wrong? Why do we need drugs?
Well, like any system, it can fail.
Yeah.
And it tends to fail in two main ways. You get way too much hormone or you get way too little.
Okay, let's start with too much.
Too much glucocorticoid leads to a condition called Cushing's syndrome.
Cushing's? What does that look like? If you see a patient, what are the telltale signs?
The most classic visual sign is that strange fat redistribution. You hear about the moon face. The face gets very round, and fat tends to move away from the arms and legs and collect around the face, the upper back, sort of the trunk area.
Huh. Why does that happen?
It can be caused by a few things. Maybe a tumor on the pituitary or the adrenal gland itself, pumping out too much hormone. But Really relevant for us, it can also be caused by giving someone high doses of steroid medications for too long, exogenous steroids.
Ah, so the treatment itself can cause a Cushingoid appearance.
Absolutely, it's a major consideration with long-term therapy.
Okay, that's too much. What about the flip side, too little hormone?
That's Addison's disease. This is usually a chronic condition. Often it's the patient's own immune system mistakenly attacking and destroying the cells of the adrenal cortex.
Autoimmune destruction. And the symptoms. Are they obvious?
They can be kind of vague and nonspecific initially, which can make diagnosis tricky. Fatigue, weakness, weight loss. But the key clinical signs we look for are things like dehydration, low sodium levels, hyponatremia, and high potassium levels, hyperkalemia.
Low sodium hypotassium. Okay.
And often, a really striking sign is hyperpigmentation. The skin can get noticeably darker, especially in skin creases, scars, or areas exposed to sun.
Wow. Okay. And Addison's can become an emergency, right?
Yes. This leads to the most critical situation. Adrenal crisis, sometimes called an Addisonian crisis. This is an acute, life-threatening emergency.
What happens in an adrenal crisis?
It's a sudden, profound drop in glucocorticoids, and often mineralocorticoids too. The patient's blood pressure plummets, fluid volume crashes, sodium levels drop dangerously low, potassium spikes. They can go into circulatory collapse very quickly if it's not managed immediately.
Okay. High stakes indeed. So we have these disorders and we have drugs. Let's talk about the drugs themselves. How do they actually work at the cellular level? We said they're made from cholesterol.
Right. And their mechanism is quite interesting. Unlike a lot of drugs that just bind to a receptor on the outside of a cell, steroids are lipid-soluble. They actually pass right through the cell membrane.
Inside the cell.
Inside the cell. They bind to a specific receptor protein floating around in the cytoplasm. This new steroid receptor complex then travels into the cell nucleus.
Into the nucleus, where the DNA is.
Exactly. And once inside the nucleus, this complex actually binds to specific parts of the DNA. This binding either stimulates or suppresses the transcription of certain genes into messenger RNA, mRNA.
So they're changing gene expression.
Precisely. That mRNA then serves as a blueprint for the cell to make new proteins or sometimes stop making certain proteins. And it's these new proteins that ultimately change the cell's function and produce the steroid's effects, like reducing inflammation or altering metabolism.
That explains why the effects might not be immediate. The cell has to actually build these new proteins first.
Exactly. It's not like flipping a switch instantly. It involves protein synthesis, which takes a little time, but the effects are profound and can be quite long-lasting.
Fascinating. So knowing that, let's talk applications. Where do we use these glucocorticoids? Obviously for deficiency like Addison's.
Yes, replacement therapy is one use, but honestly, the vast majority of glucocorticoid use is for their powerful anti-inflammatory and immunosuppressive effects. Think severe asthma attacks, flare-ups of rheumatoid arthritis, preventing organ transplant rejection, treating severe allergic reactions. The list is long.
Very broad applications then. Is there a specific use case maybe our learners should really lock down, something high yield?
Definitely. A really important one, especially in obstetrics, is the use of beta-methazone or dexamethasone in pregnant women who are at risk of delivering prematurely.
Preterm labor. Why give steroids then?
So if delivery looks likely between about 34 and 36 weeks gestation, giving the mother these specific glucocorticoids is standard practice. They cross the placenta, get into the fetus, and actually accelerate the maturation of the fetal lungs.
How does that work?
They stimulate the production of surfactant in the fetal lungs. Surfactant is crucial for keeping the little air sacs, the alveoli, open after birth. Giving these steroids significantly reduces the risk and severity of respiratory distress syndrome in premature babies. It's a major intervention.
Wow. Okay. That's definitely one to remember. Let's zero in on some specific drug names now. What about that mineralocorticoid replacement?
For pure mineralocorticoid activity, there's really only one player. Fludrocortisone, brand name Florinef. It's used specifically for mineralocorticoid replacement in Addison's disease and also in a condition called salt-losing adrenogenital syndrome.
And given its job is sodium retention, what are the main side effects to watch for?
Predictably, it's all related to fluid and electrolytes. Too much sodium and water retention can lead to hypertension, edema, even heart failure in susceptible patients. You also have to monitor potassium levels.
Makes sense. And for the glucocorticoids, what are the common ones we see?
The go-to oral intermediate-acting glucocorticoid is prednisone. It's widely used, has relatively minimal mineralocorticoid effects compared to its anti-inflammatory action, which is often desirable.
Prednisone, okay. And what about injectables in the hospital setting?
The most common IV glucocorticoid you'll encounter is probably methylprednisolone, brand name Solumedrol.
Solumedrol, got it. Anything tricky about that one?
Yes, absolutely critical point here regarding safety. There's a huge potential for look-alike, sound-alike errors between methylprednisolone, Solumedrol, and hydrocortisone sodium succinate, Solucortef.
Oh, how so?
They sound similar. They're both IV steroids, but their potencies are very different. You must know this. 4 milligrams of Solumedrol provides the equivalent anti-inflammatory effect as 20 milligrams of Solucortef.
Wait, 4 equals 20, so Solumedrol is 5 times stronger?
Exactly.
Yeah.
5 times more potent. They're absolutely not interchangeable milligram for milligram. Mixing them up can lead to massive dosing errors, either dangerous overtreatment or critical undertreatment.
That is a huge safety point. Definitely something to double check.
Always.
Okay, these drugs are clearly powerful, effective, but that usually comes with a downside. Let's talk about the risks, the contraindications, the adverse effects. This is where it gets, well, complicated.
It really is. Because they suppress the immune system so effectively, a major contraindication is the presence of a serious infection, particularly systemic fungal infections. You generally don't want to suppress the immune response when the body is fighting off a major invader. Also, active varicella chickenpox is a big one to avoid.
Okay, infections. What else?
We use them with extreme caution if a patient already has conditions that steroids can worsen. Things like peptic ulcer disease, because steroids can irritate the stomach lining. Glaucoma, because they can increase eye pressure. And diabetes mellitus, because they reliably raise blood sugar levels.
Right, the hyperglycemia effect, that's a common adverse effect, isn't it?
Very common, especially in hospitalized patients getting higher doses. You'll often see blood sugars go up significantly. Another common one, sometimes quite distressing for patients, is steroid-induced psychosis or mood changes. And with long-term use, you see those physical changes we mentioned with Cushing's, like the moon phases.
But what's the most serious, the most fundamental adverse effect we worry about with long-term use?
Without a doubt, it's HPA axis suppression.
Back to the HPA axis. How does taking the drug suppress it?
It's that negative feedback loop again. If you're constantly supplying the body with corticosteroids from an external source, the medication, the hypothalamus and pituitary get that signal that levels are high. So they stop sending out CRH and ACTH.
So the body's own production shuts down.
Exactly. The adrenal cortex isn't getting the signal to produce hormones, so it can actually start to atrophy, to shrink over time. The body becomes dependent on the external source of steroids.
And the danger there is?
The danger is, if that external source is suddenly removed, if the patient abruptly stops taking the medication, or even if they encounter a major physical stress like surgery or trauma, their own adrenal glands can't ramp up production quickly enough.
Leading
straight back to that potential for adrenal crisis, acute adrenal insufficiency. It's the most critical long-term risk.
Okay, that's huge. What about interactions with other drugs?
Very important ones to know. First, combining corticosteroids with other drugs known to cause GI ulcers, like aspirin or NSAIDs, ibuprofen, naproxen, significantly increases the risk of gastric bleeding and ulceration. It's an additive effect.
So avoid aspirin and NSAIDs if possible.
Definitely counsel patients on that. Second, watch out when they're used with diuretics, specifically the non-potassium-sparing ones like furosemide or hydrochlorothiazide. These diuretics already cause potassium loss, and corticosteroids can also cause potassium loss. Together, they can lead to severe hypokalemia, dangerously low potassium levels.
Okay, monitor potassium closely. Anything else major?
Yes, with anti-diabetic medications. Because steroids raise blood sugar, they counteract the effects of insulin or oral hypoglycemic drugs. Patients with diabetes will almost certainly need their diabetes medication doses adjusted, likely increased, while on steroids.
Right. Constant monitoring needed there. This all leads perfectly into the practical side, the nursing considerations. What are the absolute must-dos when managing a patient on these drugs?
It starts, as always, with a thorough baseline assessment. Given those metabolic effects, you absolutely need baseline serum sodium, potassium, and glucose levels, and you need to monitor them throughout therapy. Expect glucose to rise, potentially potassium to drop.
Checking electrolytes and sugar. What else?
Assess for any pre-existing conditions that could be worsened, like peptic ulcer disease, heart failure, diabetes. Look for signs of fluid retention, edema, weight gain, which could indicate mineralocorticoid effects, or worsening heart failure. Get a baseline weight.
Okay, solid baseline. Now, when actually giving the medication, what's key?
Timing is surprisingly important, especially for minimizing that HPA axis suppression with long-term therapy. The body naturally produces a surge of cortisol in the early morning. So we try to mimic that
Yeah.
by giving exogenous glucocorticoids early in the morning, ideally between 6 a.m. and 9 a.m. This coincides with the body's natural rhythm and is thought to cause less suppression over time compared to, say, evening doses.
Given with breakfast, essentially.
That's a good way to think about it. And speaking of food, oral forms should always be taken with food, milk, or an antacid to minimize GI upset.
Good tip. And remind patients to avoid
Alcohol, caffeine, aspirin, NSAIDs, anything that could further irritate the stomach.
What about inhaled steroids? Specific instructions there.
Yes, very important teaching point. Inhaled corticosteroids used for asthma or COPD are maintenance therapy. They are absolutely not rescue inhalers for an acute attack. Patients need a separate bronchodilator for that.
Okay, not for emergencies. And after they use the inhaler.
They must rinse their mouth and throat thoroughly with water and spit it out after each use. This is critical to prevent developing oral candidiasis, a fungal infection, basically thrush, in the mouth and throat.
Rinse and spit. Got it. Now, we talked about HPA axis suppression being the biggest long-term risk. This leads to what is probably the single most important rule.
The absolute cardinal rule, the one you cannot forget. Never abruptly discontinue corticosteroids, especially after long-term use.
Okay, let's hammer this home.
Because, as we said, the patient's own HPA axis is likely suppressed. Their adrenals aren't working properly. If you suddenly remove the external steroid source, the body has no way to produce its own cortisol quickly.
And that leads to
Adrenal insufficiency, which can rapidly spiral into that life-threatening adrenal crisis, severe hypotension, shock, circulatory collapse. It's a medical emergency triggered by stopping the drug too fast.
So how do we stop them safely?
You must taper the dose. Gradually reduce the daily dose over a period of weeks, sometimes months, depending on the dose and duration of therapy. This slow reduction gives the HPA axis time to wake back up and gradually resume its own hormone production.
Tapering is non-negotiable.
Absolutely non-negotiable.
And related to this, what's the stress dose concept?
Right. So if a patient is on long-term steroid therapy, maybe the equivalent of 10 milligrams or more of prednisone daily, their HPA axis is presumed to be suppressed. If they then face a major physiological stressor like surgery, significant trauma, a severe infection, their body won't be able to mount the necessary cortisol surge to cope.
Well, they need extra.
Yes, we have to give them supplemental higher doses of steroid stress doses perioperatively or during the acute illness to mimic the natural stress response and prevent them from crashing into an adrenal crisis. It's proactive management.
Crucial point for anyone on long-term therapy, undergoing procedures, or getting acutely ill.
Absolutely. They might even need to wear a medical alert bracelet stating they're on long-term steroids.
Okay, that's a lot to cover, but incredibly important. Let's try to summarize the key takeaways from this deep dive. We've seen the adrenal cortex makes these vital hormones, glucocorticoids for inflammation, stress, metabolism, and mineralocorticoids for salt and water balance. The HPA axis keeps it all in check through negative feedback.
And the drugs we use, primarily glucocorticoids, are powerful anti-inflammatories, but come with significant risks, the biggest being HPA axis suppression if used long-term.
Which means meticulous management is key. Morning dosing, taking with food, avoiding irritants, rinsing after inhaling, and the absolute golden rule.
Never stop abruptly. Always taper, and consider stress dosing for major events.
So maybe a final thought for our listeners connecting this back to their practice.
Well, given how these drugs impact almost every system, immune, metabolic, cardiovascular, CNS, musculoskeletal, it really underscores the huge responsibility we have, doesn't it? How vital is thorough patient teaching? Making sure they understand the diet changes, the need to avoid infections, and critically, knowing exactly which signs and symptoms like a fever, unusual weakness, or sudden significant weight gain mean they need to call their provider immediately.
That really brings it home. The power of the drugs demands an equal measure of vigilance and education from us. Thank you so much for walking us through that complex topic, and thank you, our listeners, for joining this deep dive into adrenal drugs. We hope this helps clarify things as you continue your learning journey.